I appreciate you guys coming and to what's part of a series, the Biostatistics and Epidemiology Grand Rounds, that oftentimes in Charleston we have the good fortune of watching via video conferencing. And welcome those to those in Morgantown. Now you kind of get our perspective, which we do appreciate that, but it really certainly I'm glad to have somebody here live and in person. And so I appreciate Dr. Dino and Dr. Cottrell, who's going to be speaking with us today, for being here and taking the time out to come down to Charleston to have this presentation. To speak a bit about Dr. Cottrell, let me share a bit of our bio sketch with you. She's a tenure-track associate professor in the Department of Pediatrics in the School of Medicine and has a doctorate in developmental psychology. Her training included a NIDA-funded doctoral project examining parental monitoring and adolescent risk behaviors, including substance abuse and unprotected sexual risk. She's a co-principal investigator in the WVU Prevention Research Center and vice chair of research for the Department of Pediatrics. Her current research interests examine parental influences on child and adolescent health risk decision-making and behaviors. She is the principal investigator for the Marion County, West Virginia location on the National Children's Study and a co-investigator on a funded grant examining the impact of obesity in preschool children. She is currently conducting clinical translational project examining the association between asthma and obesity among children. And I think there's maybe some meetings that will be preceding this one where she'll be meeting with some of the folks here from our campus and talking about this obesity summit. This is something that she's one of the founding, I guess, folks for the obesity summit that will be coming up, I think, in May, that a lot of you might be attending. So without further ado, Dr. Cottrell.
Thank you, Dr. Thank you. So when they say it takes a village, it definitely does to get me to present. So I appreciate a couple of people, particularly Andrew Dunn and Cindy Hanna, for coordinating this. It's a really nice pleasure to be here in person. It really is. But they did a lot of work to make it happen, so we are very thankful. Michael Regier, who asked me and got me into this. I owe you one, Michael, but it's fun. You know, Michael asked me, and I'm short, so I'm going to go a little bit. If I'm outside of the scope, guys, let me know of the view. But when Michael asked me to give a biostatistics grand rounds presentation, I have to admit my initial response was in shock, because I am a developmental psychologist who works with communities and clinicians, and I get really, you're going to see that I am definitely not a biostatistical person. And Michael and Krista or Lily know that. But what we did note that we could talk about today is when we're working with communities and in clinics, there are many times where we're faced with the balance of trying to establish a rigorous scientific product or information that comes out of it, and then also meeting the needs of those we're working with, we're partnering with. So that's what we're going to talk about today. Okay. Okay, and so in terms of objectives, want to go over, this is a perfect time, since we're talking about community collaborative research. I cannot let this pass without talking about some of the principles of that type of research. So we are going to talk about data, but we're also going to talk about just kind of those partnerships in general. So the first objective or outcome of this is really to look at the guidelines of those partnerships. If we want to establish this nice balance between scientific rigor and appropriate partnerships, what does that involve? Second is kind of compare and contrast those guidelines. As those viewing this presentation, I want you to think about those that you do, those that you don't do, with your own experiences, and then I'm going to give an example from my own experiences and see. I always learn best with an example or visual, and so hopefully that'll help. And then finally, before you leave or as you leave, begin to translate these guidelines into your own plans if you do collaborative research. And again, I'm talking a lot about within communities, working with health departments and schools. The audience, the partner may differ. It may be providers. It may be some other, faith-based organizations. But the process is very similar. So we're going to talk about that. So briefly, researchers and community partners come to the table with the same thing. There's a shared need or concern, right? However, we come with very different definitions. The community comes with a definition of a need based on a practice gap. Something is missing, and it's usually a service. There's a health need, and so services are needed to reduce that issue. Researchers come to the table, of course, with a definition of a need based on scientific gap in the literature. Okay? And what we're looking for would be measures and data that help us fill that gap. So again, same interests, slightly different process involved. Similarly, we have same goals. We all want to collect new information. Now, why? That might be a little bit different. Researchers, you might want to collect new knowledge, again, based on these principles. So rigorous scientific methods, representative samples, we're looking for these characteristics. If we're building it, it must have these, or as much as possible have these, for it to stand the criticism of peer-reviewed manuscripts. Valid and reliable data. That's just the quintessential part. However, our community partners, they want that. I mean, they don't want the opposite for sure, but what they really want are the solutions to their problems. And if they can't get the actual solutions, then at least some more information getting them closer to that. That's what they want. Benefits, if we're able to do this, if we're able to partner and it happens and it's an aha moment, some really neat things happen. We should be able to reach particular samples that we might not be able to get access to. It's our community partners allowing us in. We have a face in the community. We can build opportunities, and we should build opportunities back to those communities, and they give us opportunities for research. And then for efficiency. We all like efficiency. So those are some of the benefits from that. And I know I'm speaking to the choir. Many of you out there are already doing this and know this. But again, I couldn't let the opportunity pass without talking about that. Challenges. These top three, again, partnership building, more so than the data portion. So lack of trust and respect for researchers coming in because they've been there before and they've been used. Inequitable distribution of power. Usually communities feel like the power is not in their hands. Control is not in their range of things to use. Things that pertain to our discussion in particular today. Different emphasis on the task and process. The data that we're looking for, the vision of that may be very different, and it's worth several conversations about how to meet in the middle for that. Time to gather that data. Again, if someone wants a solution, they want it now. Talking about timelines. Figuring out meeting in the middle might give you a little bit more data collected in a more rigorous way while meeting the needs of their timeline in the communities. And then competing demands are always in place. Solutions. Communication, communication, communication. So jointly developing operating norms. If you say you're equal, or if you say that there are various people who have different roles, what are they? And just putting it out on the table and working it out. Identify common goals and objectives. Yes, maybe we can't solve the whole problems of the community. Here's what we're going to focus on here, and here's why we need to focus. That's the scientific rigor coming in a little bit. Leadership, democratic leadership, people range. Community engaged research, it ranges based on how much the community is involved, how much the researcher runs it. And then identified roles and skills and competencies we've already talked about. Then finally, assess what information is already available. Sometimes we don't think about this, although sometimes it seems like the first stepping point. Secondary data analysis, right? We think of our students coming in, their timeline is short. If they have the opportunity to access data that's already collected, fantastic. We know that there's some limitations because they didn't get a chance to design it. Do we have that kind of a model in the communities? Maybe. Maybe. I know from being from a clinical department, there are many data collection points that were originated for service only. They were never intended for research. But looking at it from a researcher's perspective, it is a wonderland of information. Community doesn't look at it, or hasn't in the past looked at it in terms of research, but could it be, right? So having those discussions, what's available, who collects what, how does that align with our goals? That might save you a lot of time down the road. Okay. So these guidelines, several guidelines have been published in various forms of the literature. Here are some, and again, some are more process-driven, some are directly pertinent to the data portion of this process. If you are in the researcher role, be a consultant, co-learner, facilitator, right? This co-learner. You have skills, you have expertise, granted. What don't you know is the important part too. Positive working relationship, this seems like a duh comment, but we all know, and we could probably say, give some examples of what went wrong. We all know people who just really had bad experiences, and if we thought about why, maybe that working relationship wasn't built as strong as it could be. Respect others, again, that's another definitely, but it doesn't necessarily happen all the time. We've already talked about asking questions about available resources, talking about possibilities and strength, never doubting or overlooking the strengths of what the community can provide. Same thing as yours. They may not know what strengths you bring, even though you might think it's obvious. Based on your literature, they're not reading the literature many times. Okay? They might be, but you shouldn't go in thinking. Potential application of resources to the team. Again, what's the long-term goal of this team? Hopefully you're not just connecting with them for this one project. And then you're committing the fallacy of community projects to begin with, going in one time, leaving, never to be seen again. So hopefully you're going in for a sustained relationship. Research-wise, that makes a lot of sense, right? This sounds very selfish, but I'm just going to go there because that's a lot of the output. How many things can you get out of this research? How many publications? How many presentations? Do you need to be the first author every time? What agencies should you apply to? That timeline needs to include, do you go back and talk to the state board for education and for health? Share your findings. At what point? Now, obviously, those will change as needed, but laying them out is important. Personal investment to you. Do you have the time to do this? And then what is your role based on that time? Now this last one is just an example of the strength. So researchers, biostats, you're coming in as kind of an equivalent of this godlike power. You know statistics. You can make it happen. You can interpret. We can help interpret as well. You have these services. But then there's also things, other software, Dropbox, sharing, that add to the communication, things that any academic individual, not just biostats, but any academic individual has access to. One, from the example I'm going to give, is simply having access to the articles. Through our WVU system, many of the journals they've purchased. So we don't get that you need to pay to see this article. Communities do. So if they have been wanting to get information, not everything's open access. That's a resource you automatically provide. All right, so I'm going to give an example, my experiences of all of this, and share some data. Here's where the data is hopefully going to come in. This is meant to be a relaxed presentation, so if you have any questions, those in other sites, if you have any questions, disrupt me at any point in time while you have that thought. This is a back and forth. I definitely won't mind. Okay, so several years ago, I know automation is fantastic in PowerPoint. Several years ago, I had people talk about stars aligning, and that's what happened. These three individuals are partners that I've worked with since 2005. And so you have the pylons here representing, me sitting in the academic side. And what I was doing is obesity assessment and looking at particularly what's going on in the home, the parent, the family environment that would lead to physical activity, nutrition that would lead to the obesity that we're seeing throughout the state. I was working with the Cardiac Project, okay? Next person over, you'll see Whitberg. That's Richard Whitberg. He's the director of the Mid-Ohio Valley Health Department. Now, I had not met Richard at all. And I didn't work with health departments at all up to this point. Completely new. But he had been working in the Wood County area on physical activity efforts in their trails and other settings. And he was really wanting to reduce obesity through that way. And then you have the connector. It always seems to be this one person who brings everybody together. So Karen Northrup, she's the school nurse in Wood County Schools. She has a savvy for research. So she's already thinking about that. She's on the ball in terms of the literature. She knows her stuff. She was doing a version of cardiac in Wood County Schools. Okay, so she's obesity assessment. There's an overlap of interest here. Some physical activity, not a lot of interventions, more on the assessment side and the screenings. So Karen knows me through cardiac. She works with Dick directly in Wood County. She says, let's get together at Panera. And working at Panera outside of my office has always been, I would say, always do that. Outside of the health department, any locations that your partners work in, get out of there. Go separate. It kind of does something nice. So there's an overlap, communication. There's an equality in this group that's really different. It happened naturally, but then we also did things, we made fun of ourselves to keep that role process equal. We call ourselves the Musketeers. So 3 musketeers, but we're the stooges. We kind of make fun of ourselves, right? But it's all in an equal role. No one is higher than the other. So again, this partnership development, I'm going to keep going back to that, but also the data. So everyone, all 3 of us were interested in the obesity issue. Settings, 2 of us were in the schools in some way, particularly in the same age group, so 5th graders. Resources, so we did that. We sat down and we said, what would we want to do? So we like one another. That's step 1. We can work with one another. What access do we have? What data? So Karen had access to the health screenings, okay, in Wood County. Now, Wood County school system is pretty large. And at the time, they were using passive consent. And so they had 960 or more annually, data from kids. They had their grades. They had standardized test scores and demographics. They had other things too. But as we were going through the list, these things tended to pop out. Because we had been talking about work in California that had been done in Texas. Texas is also big. That was noticing that physical activity, improvements in physical activity or fitness as a byproduct, were increasing academics. Now, a lot of people were looking at grades. And there's some limitations to that. There are limitations to many measures. Not as many were looking at standardized test scores. Not a lot of people have access to them. FERPA, for one, I mean, they're difficult to do. So we thought, let's do that. Let's do that. We weren't talking interventions. So at this point, Dick Whitberg is kind of setting to the side. He's interested as a PhD in health department, as a director in the health department. He's interested in the science of it. And so he's not getting his interventions yet that he's really passionate about, but he's going to wait it out. He's interested in what we find. Okay. So the first study that we ever do, and I'm not going to practice what I just preached because we didn't lay out every study that we were going to do, but we had a plan. So the first study, we looked at 1 year of data. Now, interestingly, like some of the barriers I was talking about, FERPA being one, Karen is the school nurse. She's within the system. And she also knows what's needed. She also has the partners through the system WVCTSI. And so we went through some very thorough and involved steps, the way we should, to get that data. Now, Karen saw the identified data and matched everything. So the student standardized test scores with the screening. Dick and I did not. We saw the de-identified data afterwards, being the 2 outside of the school system. Okay, so things did come up that we really needed to address, but they didn't stop the studies. So you can see the mean age, these were mostly the 5th grade, so mean age 10 years, pulled for WVCTSI, which I mentioned, and the FERPA issues. I also already mentioned the passive consent. Okay, parents did have a chance when they did the health screenings to not, if they didn't want their child to participate, they could say, but otherwise they would be screened. Now we're, though, looking at that data for research. And so a letter was sent back out to those parents saying, you know, this data, this information is being examined for a different reason, and we just want you to know. Okay? And anyone who's worked with IRB, you know, if your intent changes a little bit, that's one of the steps that they pretty much recommend. So we took that step. And then I already talked about some of the things that we did to match the files. That was on Karen's side and a person from WVCTSI. Okay, so the first research question was, okay, let's establish this relationship. Many of us were looking at obesity. So you have physical fitness by the Fitnessgram. That's what the schools were using at the time to measure students' fitness level. We have body composition, and in this case, there's a body composition section of the Fitnessgram, but it's not always filled out the same in West Virginia, but we had the health screenings. So these were actual heights and weights that were assessed during the school screenings. And then the academic achievement, which was the standardized. So what is the relationship among those three variables? Does fitness, specifically, is fitness associated with academic achievement, and if so, how? Okay, and I don't know why it's doing this. Okay. All right, so I already mentioned slightly more than half were males. Okay, here are the measures, and I want to focus a little bit on this. These were, of course, data that were already collected from the schools. So it's secondary data analysis that we're talking about here. We did not have the liberty to go in and survey additionally. We could have, but what was already available. So for SES, socioeconomic status, in the current literature is very powerful, and it has a huge impact on academics. If a child's hungry, and then you can just kind of follow that down, they're not going to concentrate during school. So we wanted that really to be in the model, and we had to use a proxy, okay, a proxy measure, and that was a limitation. So we used free and reduced lunch, and this is particularly at the individual child. Is that child on free and reduced lunch? Okay, not at the school level, but was that child? Gender, of course, body mass index, percentile. Then we also had blood pressure and acanthosis nigricans from the health screening. Okay. The Fitnessgram, if you're not familiar with that, these are the scales. So there's a total fitness score that we've developed, and basically it's summing up all of the following that you see. So it's aerobic capacity, abdominal strength, upper body strength, flexibility, and trunk strength. And what you get is a dichotomous variable. Did they meet healthy, were they in the healthy zone or not? Okay, so then when you sum it, you can get a scale of 0 to 5. And then standardized academic test scores, use the West test, which has since changed. And again, only the 5th graders, but we looked at reading, language arts, mathematics, science, and social studies are the 4 areas that they get. Okay, so opportunities that we had. But we needed to have a discussion, and it was valuable discussion, about what variables we needed based on the literature. And here's where your rigor comes in with what you have. We knew that SES was important and should be in that model. We accessed what we could in the free and reduced lunch. Yes, there are better ways to measure many of these things, but this is what we have. And that's okay. You state that in your limitations, okay? But those discussions were valuable. And the other thing that we had a discussion on is, you know, Karen had talked a lot about how the school gets these Excels. She has this screening data every year, and it's very valuable to her to get back to the families, of course, to those that are at risk. But then she also felt like she wanted to do more with these Excel sheets. So, and this is what we were doing. And she always describes this as an additional benefit for her. She could apply this information that's collected for a good reason, but for other roles. Okay? And then we talked a lot about variable definitions. Okay? Why some are better than others and so forth. And then talked about interpretation. Of course, Dick was looking at all of this. If something came out for interventions, we were all looking at it for something different. Okay, so this is just visually kind of the variables that are put in. In terms of the literature, 2 big factors, like I said, SES, gender differences with females, unfortunately, having lower standardized test scores in general. BMI, when you look at the BMI distribution of this particular sample in this first study, here's how it looked. So you have the different colors represent the different topics or the different standardized academic areas. And you'll notice the big pattern I want to pull out is, of course, you know, the underweight kids had the lowest mean academic scores on whatever value, whatever area. Second lowest were the obese kids, okay? And then the overweight and the healthy weight kind of vary. There's some mixture based on where they are in the overweight range and so forth. But so what we took from that, and here's fitness level in this sample. So again, we used the total fitness in this first project rather than breaking it down. And so again, it was 0 if they were not in the healthy zone for any of those subscales, and 5 if they were in the healthy zone for all of them. And you can see, while there's some variability in some instances, it goes up. It increases. So the more fit, the higher the mean. Okay. All right. Not a lot had been done in the literature on blood pressure and AN. Okay, in terms of these kinds of outlooks. So we didn't know how that was going to pan out. But when you put all those factors together in the same model, these 3 factors were significant in terms of their effect. So you had the SES and gender, and then you had total fitness. BMI doesn't come through. You have the total fitness. So in the sense that low SES, female, and low fitness was associated with lower standardized test scores in all 4 areas. Okay, so that was our established relationship. That was interesting. We thought obesity would be in there a little bit. Fitness tended to be a little bit more stronger in terms of its effect. So then we got the bug, right? We were interested. What's going on here? Led to second study. Okay, which type of fitness then? If fitness is so important in terms of academics, and now mind you, No Child Left Behind, right? Oftentimes you get recess cut out for various academic reasons, physical activity in general, because we want to focus on these test scores. If we continue to see some of this stuff, well, that smacks in the face of that a little bit, doesn't it? Right? I mean, the higher the fitness, the better academics. So now we're starting to think, now Dick Whitberg is getting really excited because he's thinking interventions, right? Karen's getting excited because what can I tell my schools if this is the case and I want to tell them to do something, they're going to want to know what, right? So what types of fitness? All right, same sample. Again, efficiency. How can you, different research question, different or same sample? All right, so you're familiar with the same outcomes. This time, instead of using the total fitness, now we're putting in those subscales of fitness to see which ones. All right. Here's how in general, so again, remember they're in the healthy fitness zone or not. And here are the percent of students in the healthy fitness across those different fitness domains. Okay? Some are better than others. Okay? Now, some people say the way the Fitnessgram is assessed is problematic. You put that in the limitation, and we did. It's not as consistent. We're going to talk about one of the studies we did where for the same subscale, it's done differently. A mile test versus a short pacer, back and forth, or shuttle run. We're going to talk about that. But given those limitations, okay, here's what we were seeing. All right, so in terms of which fitness factors were going in, when you look across in the same colors, some colors pop up, right? Again, SES, gender. Doesn't matter what area you're looking at in terms of academics. They come through. The other one that tends to be more consistent is aerobic capacity. Now, when we started seeing this, we started talking about older adult literature as well. And we started looking at articles because if you've looked a little bit at Alzheimer's research, and the research that's trying to prolong the effects of Alzheimer's, a lot of it includes exercise and increasing activity. Okay? So to try to figure out the interpretation of a lot of this. So aerobic capacity or some type of interaction with aerobic capacity for the various. So this tells us some interesting things. First of all, not every academic outcome is equal. Slightly different fitness variables worked their way in to contribute to different levels. So that was interesting. But aerobic capacity, so if we're thinking down the road for interventions, it might be getting this moderate to vigorous, this aerobic capacity type of exercise in the physical education courses or in the classroom, get them to jump up and down. So we're starting to focus a little bit more on our recommendations. Now, we shared these. Each time we did these studies, we shared it back with the local education department, the board, okay, and answered their questions. And in Wood County, they were very, very proactive in terms of thinking about restructuring some of their curricula so that they could start getting more physical activity or recess. They're very proactive compared to some other locations just to try it out, but they needed to look at data, and this really helped and answer questions. All right. So other studies were in the between this. For instance, that I'm not going to cover for time, but for instance, how much activity do you need to see a jump? Right? So now we kind of know the type of activity, but how much do we need? And so in that one, there were gender differences. Okay? There were different types. So what constitutes being fit? Okay? This one we brought in different cohorts, right? We're starting to add to our database. Now we've established a stronger relationship with WVCTSI. We're used to that process. They're used to us and what our intentions are. The board is behind us all the way. The process gets a little bit more smooth to go down. So now we have 1941 students. Similar composition though, slightly over half are male, again within that 9 to 13 years old. Using the same types of variables, okay? Always the Fitnessgram West test, genders. Okay, briefly, here are the thresholds. So here's the design problem or the measure problem that I referenced a little bit earlier. In the state, in these years within Wood County, but it happens throughout the state, boys, for the aerobic capacity, now we know we just want to focus on aerobic capacity. Boys typically are assessed using a mile, how, you know, being able to run a mile and what's your time, how quick can you run it. Girls are usually assessed during these back and forth shuttle, how many circuits can they do. So while we had a 1-0 variable there that measured aerobic capacity, it was measured differently. Okay, and that was a big discussion, and it also played a major role in the article, the manuscript, and the reviewers, right? But with that, so what you see is there are thresholds. For boys with the mile, of course you saw that jump in all of the academics at like a 540-second mile. For girls, we saw a little bit of a jump with 12, plus or minus 12 circuits, and then another advancement in their academics if they could do 30, so between 12 and 30. So again, this was very specific in terms of the interpretation, but it was the start to figure out how long an intervention might be or what would be the goal of the intervention. I mean, worst case scenario, or at the very basic, a PE teacher could have them do these circuits or miles throughout the year to improve that. Now that's not all, you know, that's all, not all this says, but I mean, we're getting, again, closer to how fit are we talking about that they need to be to increase their academics. Okay. The difference between girls and boys. Girls' fitness is shaped differently. It takes very different interventions for girls than boys. And we know this. Literature shows us this. But in terms of their academics, the same is true. And then finally, if we had a longitudinal data set, how does all this change? Fortunately, we did. So by the time we got to this point, it was 4 years. And we knew that we were liking this, and we were getting peer-reviewed manuscripts out, and we were developing great relationships with our community partners, health department, and schools. So we wanted to keep doing it. And so we had developed the longitudinal from the beginning with the various cohorts. But how does this change over time? So you had 3 cohorts, 17, 25 students, again, similar composition. This time we had 5th and 7th grade for the longitudinal components. So the first time they were assessed was in 5th grade, second time was in 7th. So here we are in middle schools. That was a slightly added challenge because you're technically in a different system. You're still within the Department of Education, but middle schools from elementary schools, very different people, very different processes. West Test and Fitnessgram the same. Okay. So you had 4 groups, essentially. You had those students who were in the healthy fitness zone, and here again we're only talking about aerobic capacity, okay? They were in the healthy fitness zone as a 5th grader, and they stayed there that way as a 7th grader. You had those that lost it, lost the fitness as a 7th grader, those that gained it, and you can see the numbers, and those that never were in the healthy fitness zone as a 5th or a 7th to begin with. And those were the 4 groups that we were looking at in terms of their academics. All right, so for each, so this is math in the 7th grade. And our colors are very similar. So the higher average means in math were the students who had maintained a healthy fitness from 5th and 7th. Okay? The lowest mean were those who were never in it. Okay? The middle is a little bit different. And the middle group actually were the groups that we were most interested in. Because if you do an intervention, if they did something in 6th grade and became more fit in that short period of time, I mean 2 years is pretty a short period of time, could they have a change in academics? Other factors are going on. So the main picture here is if you can keep it, you're better off. If you can get there, first of all, if you can get in the healthy zone and you can keep it, you're going to be better off. If you never get there, you're going to be worse off. So we know that. Middle, we still need to do a little bit more. That's the same for science, and it's the same for reading. Now, slightly different patterns going on. You can see in the middle ones keep changing a little bit of which ones had lower mean scores. For instance, the purple here, so the purple is those who improved their fitness. They still had lower mean scores on reading, but not as bad as those who had lost fitness in that 2 years. And then the same thing for social studies. And interestingly, we've talked a lot about how these academic areas differ and might pull. How does fitness affect one so positively and not as much in another? Math seems to be very vulnerable to fitness. Science seems to be very vulnerable. Reading, not as. Social studies, not as. So maybe, again, it's talking about the application or the type, whatever that academic area is pulling, also would be an interesting area to look at. Okay, so again, fitness and academics can be sustained over time if we can get them there and keep them there. It's great. And in the improvements, we're hopeful about the improvements, but like I said, we need to look at it a little bit more. Okay, so just to recap, so that again was just an example of 4 or 5 studies that came from a community collaborative research, mostly on existing data. Since there are other studies that I've done with them, with summer school kids, that involve more interventions, with within the communities. Once the kids had lower fitness, and they take the West test in the spring, then over the summer, so they don't lose. You know, a lot of that is they might lose the academic part. What happens there? So we've initiated other projects, but this in particular, I hoped it would be helpful because there's just huge benefit out there for everyone within our communities. Clinics, same thing. I mean, again, you have all kinds of information that you're collected for the care of the patient that could be looked at slightly different for research. So the very same thing could be applied here. But to recap kind of the first half and how that relates to the example, and again, be thinking about your own, what you've done and what you're planning to do. So rigorous scientific methods, absolutely. Absolutely. Yes, we had several limitations that we added in our study that we knew were innate. But they passed rigorous review. Okay, so it definitely does. Representative samples, absolutely. Absolutely. When we look, I didn't share all of the demographics for the kids, and perhaps, this one was a little bit, it had passive consent, so most, like -5 kids participated. That helps a little bit, versus if you had 50% of the kids or something else participating. But we had that, and it was a community-based project. Valid and reliable data. Yes. More work is needed to see how. We could do a little bit more in that area. Find a solution that works or know more about what will work. So this is from the community. Yes. Okay, so Karen, what she was interested in when she got to the table. Dick, absolutely, what he was interested in. I think we fulfilled all three of our goals to some extent, plus more, working on these projects. Was I able as a researcher to access particular samples? 900 and plus kids in the academics, West test scores, fitness, yes, absolutely. Have a face in the community? Yeah, when I'm standing in front of the school board as part of a team who did the research, yeah, they at least know my name and they associate me with people that they work with on a daily basis, so that was a great benefit for me. Build opportunities. We brought in, Karen did a PEP grant that was around this a little bit. Additional funding went into the schools, and efficient. I think the amount of products and the projects and hopefully the benefit to the participants was efficient based on the time that we had. Okay, I'm not going to go through all of these, but in my mind, and I'm biased, we did a lot of these. Like I said, you need Karen and Dick up here to ask them if I acted any differently at the beginning of our relationship than I do now. I would say that they would say I acted just as silly as I do now, and that might have helped. But I think a lot of these were just natural. I've had other community relationships that just took a little bit more work, and you have that in any type of partnership. Okay. All right. So I just wanted to recognize my collaborators on these projects. So Dick Whitberg, Karen Northrup, Jennifer Law, who's at UNC, she's an endocrinologist. She helped us tremendously on looking at things when we started looking at the AN marker by the end of this. Again, some of the health screening data that Karen had collected. And then Krista Lilly, who's up in Morgantown with the Biostatistics department. Okay. So any questions?
I think that was a wonderful presentation and you did a beautiful job of combining the research project and the community side. And
thank you.
I was curious. Folks to keep them engaged, keep things moving along. How frequent are those interactions?
So is that okay? So the question was, how frequent were the interactions to develop the partnerships? And at first they were very often. Now we reach out to one another so often about other things that they're still often, but just not related to our direct research. So at first I would go down to Parkersburg, and there's a fabulous restaurant there, and we'd have our research meetings. And then the next visit, they'd come up to Morgantown. And we did that back and forth at least monthly when we were getting the databases together and setting out our items and all of that. And then it grew to, then we were doing publications and stuff like that, so a lot more email. Now Dick's an adjunct to the School of Public Health, and so he's, he might email me about grants that come through. Karen's the same way. Karen's and Dick are both on and Nancy are both on the core research project, which looks at very similar things for the Prevention Research Center. So it's just led to so many other things. But monthly at the beginning. Yeah, sure.
Just to follow up on this question, I'm going to take you back to the beginning. You talked about overlapping interests. How did you identify those individuals who was having an overlapping interest, and how was the reach out done? Can you elaborate a little bit about?
Sure. Morgantown, do you mind to turn off your speaker? We hear conversation. Sorry. Thank you. That's all right. Yeah. Hi, Michael. Okay. Thank you. So it's Karen. It was Karen. In terms of overlapping, you know, I knew that my interest overlapped with Karen from the screening side. She knew that she overlapped with Dick on the interventions for obesity side. And then she said, I need to get all of us together. So it was really that. Having that individual to see, you guys need to talk, was part of it. Does that answer your question? Okay. Yes?
My question has to do with, you said you were surprised that obesity was not part of the fitness piece, or the composite fitness piece.
Mm-hmm.
Are you still surprised?
No. Part of that was my lack of closeness to the literature. But then the literature grew, no pun intended, Jerry's coming out again. Literature grew as we were doing this. So now you start to hear phrases of fit obese, non-fit obese. And Dick coined the term of it's not the shape you are, but the shape you're in. You know, so now it doesn't. But I've seen this, and then California continues to do a lot of research, Texas, and many people are seeing that the obesity could be there with fitness, and there's a buffer there that the kids get. But I was very surprised. I was under at the time, I was under the impression that obesity was the hub of all things evil. That's a drastic thing. But, you know, that it was going to be centering off obesity, and it didn't.
Well, thank you. Oh, you know, right. Having a child who's in the 1st percentile for BMI, what percentage of the kids were in the underweight group?
Yeah, you had about 5% of the kids who were in the underweight group. And now that group, we tend to not interpret that underweight. We haven't in our literature, not interpret much about the underweight group. And that's a problem. There was something that we had looked at before where we thought, no, we're not doing the kids just by taking that approach. The reason why first we didn't interpret them that much is because the underweight group might include kids who are, for medical reasons, underweight. And so they tend to be the ones that have the lowest needs. And perhaps if you teased out the ones that are underweight for medical issues and those that are just underweight, you might see very different scores. And so we did interpret it because so many other things could be in that group. But it came out during the summer school that the underweights actually look very different within that group. And so in our current ones, we're detangling them if we have that data. You know, for this work, we didn't have their medical history. We didn't pull that from the list. We just would have that in there, but we didn't pull that. That would be something we look at. But about 5%, usually in samples throughout West Virginia, that's the typical for underweight, regardless of the reason. Well, thank you. Thank you for hosting.